Hello, good morning, good afternoon, depending on where you're joining from today, and welcome to today's webinar on First Nations, Inuit, and Métis experiences with racism in healthcare systems. Before we get started, next slide, please. Just a few housekeeping items. We're pleased to offer French simultaneous interpretation provided by Ken Rosbach Communications for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. If you do not see the interpretation menu on your screen, please select the icon with the three dots inside a circle, and it'll be on the toolbar at the bottom of your screen, the More menu, and then you can select interpretation. As a reminder, this will be a panel presentation, so please ensure you keep your microphones off during the webinar. We invite you to drop any questions or comments for our speakers in the chat, and we'll come to those at the end. And if you need technical support at any time during this webinar, you can reach out to one of our producers, Kaylee, Mihaela, or James, using the direct chat feature. It's important that we collectively create an environment where everyone is supported and has the space to learn, unlearn, and to reflect. If you find that you need to take a pause during the session, please do so. And we are also posting links to some mental health resources if you feel the need for additional support during or after this webinar. Next slide. So, again, welcome to everybody. I'm so happy that you've chosen to join us today for this webinar. My name is Nicole Robinson, and I work as the Director for Northern and Indigenous Health at Healthcare Excellence Canada. My mom is Métis, originally from the Red River in Manitoba, and my dad is a Welsh and English settler who grew up in and around Toronto and Peterborough in Ontario. Today, I'm joining from unceded, unsurrendered Algonquin territory where I live. I'm joining from my home office and I'm raising my two beautiful boys. I'm an uninvited guest on this territory, and that's something that I am incredibly grateful for every day, and something that I speak to my children a lot about as I raise them on this wonderful territory. Next slide. On the slide, you'll see the land acknowledgement that we as HEC use in our work across this country. And I encourage you all to introduce yourself in the chat and to take a moment to reflect on the lands that you're joining from. And if you're unsure, a really great resource is nativeland.ca with the dash, native-land.ca. You can look up and find out more about where you're joining from. As a guest here on Algonquin territory, I'm always delighted to have the opportunity to welcome a wonderful human being that I have the great privilege of being able to work with, Algonquin knowledge carrier Monique Manach, and she's going to join us to open this discussion in a good way. With that, I will pass over to you, Monique.
Jimmy Gwitch, thank you. Well, I'd like to say Bajashig, welcome. This virtual meeting is being broadcast from Algonquin territory. Monique Manach and Dejnakas, Kitikanik and Ishnabek and Dojaba. My name is Monique Manach, and I'm a member of the Algonquins of Barrier Lake. And I'm always thrilled to work with the HEC. I find the people and the experiences to be very heartwarming, very honest and genuine. And honestly, I think I get more out of it than I contribute. So I'm always happy to be here. When we're talking about racism in the healthcare systems, it's something that far too many Indigenous people have personal experience with. The deaths of Joyce Echaquan and Brian Sinclair were only the tip of the iceberg. Those are two that were highlighted. However, this racism occurs every day. In my own family, my son's father had been brought by hospital with a head injury in Toronto, and by ambulance. So the attendants were to remain with him. However, he was able to leave for some reason. He escaped, but it cost him his life. they didn't look for him. They didn't, I don't know what negligence occurred there, but I do know that as a result, he passed. And I wonder, you know, and also I've seen it with elders in my community. I had a cousin who was very ill, diabetes and heart issues for a long time. And we always had to make sure there was somebody with her from the family, because we were never entirely, and this was in Quebec, we were never entirely sure who was going to come through that door from the hospital, a nurse, a doctor, you know. So we were just very vigilant to make sure that one of us was with her, because we had that concern, and it had happened to her in the past. So, I mean, this is a systemic issue. This isn't just a one-off, or this isn't, in one place or one time. It's systemic. And how we can educate people. I know it's difficult to try to educate people out of racism, but I think the first place to start is to humanize the Indigenous community, humanize the doctors and nurses. Just if we see each other as human beings, I think that's a good place to start. And so I would like to open today's discussion. I'm so glad this area is being addressed by the HEC. And I'm going to do this. And in doing so, when we do an opening ceremony, it creates a space of safety, of honesty. It's a place where you can feel free to say what's in your heart and on your mind. It's a sacred place. It's a place where we respect each other and respect the natural laws of the Creator. And in that, I mean that we care for one another, So I'll just open the space with a few words. Thank you, Creator. We are grateful for everything the Creator has placed in our homelands that help human beings to live well. We acknowledge and honor the trees, the rivers, the lakes, the streams, and the oceans. We acknowledge and honor the birds, the animals, the fish, and all the good human beings. We're grateful for the sky world above us. We're grateful for our mother, the earth, and all the things that live beneath the surface of the earth. We acknowledge and honor the bees and insects and everything that help plants to grow. We acknowledge and honor our medicines and ceremonies. We thank you for our ability to prepare ourselves spiritually for the spirit world for when the short physical life ends. We thank you for our ability to comfort each other and bring peace to one another, especially during times of trouble and anguish. We ask that you fill this space with your goodness. And we ask that you help each of us reach the wisdom of our own ancestors and bring that wisdom here and share it with everyone here today. We ask that good words are spoken, strong words that will impact us spiritually and emotionally. We remember our friends and family who are ill, whether mentally, physically, or through addictions. And we hope they have a good day today and that they return to us soon as role models and as mentors. And we remember to live our lives with great respect for all living things. Kachimigwich, Kachimigwich, Chimigwich, Kachimigwich. Thank you very much. I know we're going to have a terrific discussion today. Thank you.
Thank you so much. Always such appreciation for the opportunity for you to join us and for us to pause and begin our time together in that kind of a grounded way. Segue to what is CPSW? If we can go to the next slide, please. So Canadian Patient Safety Week, which is organized by Healthcare Excellence Canada, is an annual campaign that aims to inspire extraordinary improvements in healthcare safety and quality. And this year, for CPSW 2024, we're focusing on broadening our understanding of healthcare harm. To learn about our theme, register for CPSW, plan to organize your own activities, explore harm with our infographic, and engage with your colleagues using an activity card. You can find out more by visiting Understanding. We encourage you to do so. And also encourage you to check out our Rethinking Patient Safety discussion guide to help you to have those conversations. We also want to take this opportunity to point you to our recently released Patient Safety Essentials, which is a free 6-module self-directed program designed especially for healthcare providers to provide the essentials to understanding patient safety. And you can sign up using the link that's going to be put in the chat. Next slide, please. Recognizing and reducing harm is essential to creating safety for everyone. But what is healthcare harm? What comes to mind when you think of healthcare harm? These are the questions that we're exploring during this Canadian Patient Safety Week, and we're thrilled that you've chosen to join us today to learn more about CPSW and healthcare harm. As Monique mentioned in her opening, racism experienced by First Nations, Inuit, and Métis continues to be a significant safety and quality issue in healthcare systems. Racism in itself is harmful and leads to healthcare harm and death, a fact well known by First Nations, Inuit, and Métis and brought to better public attention through the tragic deaths of Joyce Echaquan and Brian Sinclair and associated inquiries and reports. During this webinar, panelists will discuss First Nations, Inuit, and Métis experiences with the healthcare system and the real impact of racism, safety incidents in the form of dehumanization, and also the further harms that result from racism. In addition, First Nations, Inuit, and Métis leaders from different regions in Canada, who are our wonderful panelists, will discuss the ways healthcare organizations are addressing systemic racism and improving cultural safety of care. It's essential to understand that there is great diversity in culture, history, context, language, experience, etc., of First Nations, Inuit, and Métis across Turtle Island. First Nations, Inuit, and Métis are distinct peoples with distinct culture, language, historical, and contemporary context. And there's also diversity within and across First Nations, Inuit, and Métis. We live in every part of Canada. Many live in northern, rural, and remote parts of Canada, and many live across urban centers. Next slide, please. I am incredibly grateful to our 3 panelists for joining us today. And each of them will speak to experiences of racism in healthcare and how supporting cultural safety improves patient safety. Our first speaker will be Leah Bill. Leah is a traditional practitioner with an integrated approach to practice, combining Indigenous knowledge with nursing knowledge. She's worked as a frontline nurse in First Nations communities for over 30 years and has served as president of the Canadian Indigenous Nurses Association. This firsthand experience as a nurse led to specializing in Indigenous health research, including community participatory research, cross-cultural awareness, health promotion, and program development and evaluation. Leah is currently the executive director of the Alberta First Nations Information Governance Centre and has been there since 2019, where she's led AF and IGC in their work to promote, protect, and advance the First Nations ownership, control, access, and possession, or OCAP principles, the inherent right to self-determination, and jurisdiction in research and information management. Leah has also been an Indigenous advisor and Indigenous knowledge holder for several national health organizations, including the Canadian Partnership Against Cancer, where I had the great privilege to meet and work with her and learned an incredible amount from her. Today, Leah will be sharing about racism in emergency departments, And we'll speak to the results of a study which demonstrates that in addition to the dehumanizational related harm of racism itself, it can also lead to further physical harms. And then we have Tanya Pruden joining us. Tanya is a member of the Lac La Ronge Indian Band with Métis heritage stemming from Manitoba and Saskatchewan. She is a mother of two daughters, both young adults, and a grandmother, or Cookum, to one grandson. She lives in Saskatoon on Treaty 6 territory and homeland of the Métis, and is originally from Crichton, Saskatchewan, a border community nestled on the northern Saskatchewan-Manitoba border. Tanya's been with the Métis Nation Saskatchewan in their health department for 5 years and continues to support Métis citizens as the Director of Health for Métis Nation Saskatchewan. And she'll be speaking to the approach that Métis Nation Saskatchewan Health has taken in addressing anti-Indigenous racism in the healthcare system within Saskatchewan. And then our third speaker is Hilary Fry. Hilary is born and raised in Happy Valley Goose Bay in Newfoundland and Labrador. And is a mom to 3-year-old twin boys, which as a mom of boys, I can imagine is a handful. As a registered nurse for over 9 years and a beneficiary of the Labrador Inuit land claim, she's very passionate about achieving health equity for Labrador Inuit, which led her to complete her master's in nursing with a focus on Indigenous health. And today, Hilary will speak to recognition of racism as a patient safety issue in her region and efforts to address this through cultural safety training. We invite you to share your questions and comments at any point during this session using our chat box, and then we'll get to those during the discussion portion of our time together. And with that, I will pass it over to you, Leah. Thank you so much for being here with us today.
Thank you, and I want to acknowledge the elder for doing the opening prayer and for setting the stage for our presentations, and particularly as we move through the discussions around this topic, which is not an easy topic to discuss, and in view of the impacts it has had on our people right across the country. So I'll just have you move into the slide presentation. So my presentation is on partnership process and engagement regarding the anti-Indigenous racism work that we have done here in Alberta with the University of Alberta and many of the agencies and provincial treaty organizations who are our collaborators and partners on these projects. And if you move to the next slide. So as you can see, our partnership is quite extensive. This whole area of inquiry began when we had done initial work with the Canadian Partnership Against Cancer in looking at the experiences of First Nations patients with the cancer journey. And this started way back in 2014. And then as a result, we began some initial inquiry work with the racism that folks were experiencing. And we pulled all of these partners together to work on this very important issue. So move to the next slide. So I'm a co-lead on this project as an Indigenous knowledge holder and as the executive director from AFNIGC. Dr. Esther Tailfeathers is a physician lead on our project with this particular work. And then Dr. Patrick McLean, who is the adjunct associate professor with the University of Alberta, Department of Emergency Medicine. Next slide, please. As you can see, we have a very extensive team that has been involved in this work from the get-go, and I won't go through the entire list, but some of the folks on this list are directly linked to communities where they themselves have lead roles in addressing anti-Indigenous racism. For example, Andy Aluk, he's the chief of Big Stone Cree Nation. Eunice Lewis from Musqueam Health Services has been a long time leader in health administration and program. Same with Lorraine Musqua. And then the academic associates and partners in this work have been working with First Nations communities, Indigenous communities in the research area for a very long time. So next slide. So our background, as I initially said, actually was in 2014, a lot of the work was spearheaded where we began to identify this as a significant issue. And then in 2017, our team was formed and engaged in a mixed method study of First Nations emergency care in Alberta specifically. First Nations members expect discrimination in emergency department in Alberta, and subsequently avoid seeking emergency care whenever possible to avoid just having that negative experience. First Nations members are not triaged as needing care as urgently when you compare it with non-First Nations patients. Emergency department providers interviewed have described how racist stereotypes result in lesser quality emergency care with First Nations or former First Nations. Multi-level changes are needed in emergency departments to deliver anti-racist and equitable care. This project has been co-designed with community partners and with patients. Next slide. So the partnership development history, particularly for the work that we're currently doing, started in the fall of 2021. And then we had our initial meetings to start doing the co-design. And then in August of 22, we had a planning dinner in person with our team members. 2023, we were provided the grant monies from CIHR. And then the planning team with team of elders, which included from Treaty 6, 7, and 8. And then in 2023, we started with an opening ceremony with AHS and the elder knowledge holders that are part of our team. We ensure that we have representation from all 3 treaty areas to ensure that all of the elements of anti-Indigenous racism, which are experienced in various degrees, depending on which area you come from, they're quite unique. And so that steering committee helps to guide and direct the work as we move along. Next slide. So this is an overview of what we aspire in our project. Number one, it's a shared vision. So our aspiration is for improved knowledge and understanding of the research focus. We have shared objectives, and so it takes quite a bit of work and collaboration to co-design the goals and objectives, then to have mutual or equitable aspired outcomes, mutual rewards. And so reciprocity and equity are very key to the work that we do with give and take. Even though certain jurisdictions may perhaps maybe be experiencing it in a different way, it's always about making sure that everybody has a voice and they are contributing in an equitable way. Sharing advancements, so progress, developments, and innovations, supporting balance and equity in the research as a whole, which can be challenging at times. And so co-creation really is a real critical element of the work as a whole. Sharing information, valuing the diverse beliefs and bodies of knowledge and ways of knowing to affect real change through research. And this can be challenging too, because everybody wants to be heard, and but it's about really identifying the common threads, and with the ultimate outcome of, as our elder noted in her opening, recognizing we're all human beings and we're here having an experience, but it's about putting the humanness, a humanitarianism back into healthcare services and making it so that everybody is experiencing a good experience rather than one that potentially causes harm and death in some way. Social equity is a very key component. So understanding that resources to achieve best outcomes in and through research relationships may be unique for each partner. We know the historical context of research has always been managed and controlled by the academic institutions, and what this work has done is help to move it back into the hands of community to be the co-creators and the directors of how this particular research process is conducted, and to ensure that it's authentic research really focuses on the relations within the research as a whole. Cultural safety and ethical space are critical. Cultural safety and ethical space are essential for risk management and sustainable relationship building when it comes to particularly addressing sensitive areas of research such as anti-Indigenous racism. And then sharing the leadership. Governance of projects are inclusive of First Nation leadership principles, consensus building, knowledge, holder contributions and guidance. And our knowledge holders are not token knowledge holders. They actually are part of the whole collaborative process, even when it comes to analyzing our data and making sure that the key messages are relayed in such a way that it's not only for academic or leadership or government, but also our own people can embrace and utilize that knowledge and information for their well-being. So next slide. Our project activities to date. So our primary project goal is to improve First Nations patients' experiences and outcomes. Our complex intervention will consists of 4 activities: building and strengthening partnerships between First Nations organizations and emergency departments, training emergency department staff in anti-Indigenous racism and equity-oriented care, making structural changes to department policies and processes to support emergency department providers to offer equity-oriented care and to address barriers to follow-up care. Collaboratively documenting and advocating around health systems issues that impact First Nations members' emergency care, but that they're outside of emergency department control. Next slide. So the population and the research questions was with local emergency department implementation teams, team members, emergency care providers, and patients 15 years and older. These are the questions that are posed as part of the research project. So were quality partnerships formed between emergency departments and First Nations organizations? What facilitators and barriers impacted the implementation of the intervention? And what mechanisms, for example, intervention intensity, changes to patient-provider interactions, and contributed to the outcomes? And what specific changes to patient experiences and outcomes were achieved, if any, at the end of the project? Next slide. The role of our knowledge holders includes ensuring the work appropriately draws on Indigenous language and understanding, fostering ethical space for dialogue, ensuring the work respects land, place, and Indigenous territories, ensuring that the work respects ancestors and those who came before, and conducting ceremony in support of all above. And this is really critical because we see this as not only a research project, but an opportunity for reconciliation, for healing. And really, when you're discussing the harms that people have experienced as a result of seeking healing and help by a service provider, and then to be either rejected or mistreated, adding to their their pain and their experience is really difficult. There's a lot of healing that takes place when we're in these circles of discussion, but also in the research field itself. Next slide. The knowledge holders advisory for our projects, it's intensive work for them, and even they require debriefing at the end. And so they meet to advise on and approve all intervention guidelines, research plans, and data collection processes. They co-interpret all research findings, and they support First Nations partners working with the 3 emergency departments selected for the project as they work with departments to change departmental processes and educate staff to better serve First Nations patients. Next slide. Our local intervention teams at each site meet monthly with research staff and local emergency department leadership, local elder representatives from those particular facilities that we're working with. First Nations Youth Advisor is also involved. They're part of our team. An Indigenous analyst, educator, nurse educator, a physician knowledge translation lead, implementation champions, along with AHS staff, Indigenous Wellness Corps physician leads. Next slide. So the local implementation process and evaluation, we did extensive work with pre-implementation. It was an enormous amount of work. We have several projects. One is an intervention. We also have a simulation project that we're doing. We're pretty much halfway through. So, and it was talking to, in interviewing ED staff, surveying staff, audio recording staff, patient surveys, policy and process reviews, system-wide issues tracking and relationship building. And then we moved into the implementation, which was a 1-month-long process, emergency staff training, maintaining partnerships, and then looking at system-wide issues and tracking. And then looking at new policies and processes potentially that the system itself can begin to review and implement. And then our post-implementation phase is interviewing AUD staff once again, doing surveys, audio recording. And so there's a pre and post component to the project work. Next. Our timeline, so from beginning in 2023, so planning, implementation, and then finally the knowledge translation piece, which we hope to finish up in 2027, which will look at analysis, dissemination of results in manuscripts and presentations. But at the same time, Alberta FNIJC has a learning management system where much of the knowledge translation piece will be to help develop and train and inform service providers and leadership, particularly within the healthcare sector, to really understand the impacts of racism during the provision of care. Next slide. Our site selection process was quite extensive. And again, you had to find a site that was ready and willing to really take an honest, hard look at how their institution was impacting care of First Nations, but even looking at the racism elements and the biases that they held within their own system. And we sought direction from First Nations and considering which department, and it was the First Nations that identified the different sites where they felt that they were experiencing racism continuously and where their service was not considered good quality. We looked at zone policies and strategic plans, and the number of ED visits per year also helped to decide which sites First Nations were visiting more frequently, and then the proximity to those First Nations and the emergency department visits per year and the hospital type. whether or not there were cultural liaisons present, the norm of staffing vacancies, closures in the last 12 months, leaving without completing care rates, and the number of underhoused persons in the emergency department was also a consideration. Support of executive director, manager, physician lead, nurse champion, Indigenous Wellness Corps. So all of these folks within the system itself had to be on board in order for us to conduct the research. Next slide. So that ends my presentation. And then just a few notes. With our simulation project, we have Indigenous actors who are actually acting out real experiences of First Nations. And those roles are played out with the staff also. And the staff are invited, or they undertake the role as a nurse or a physician in that particular scenario. And the process so far, without revealing too much, has been very, very powerful. I think that the emergency staff that we have engaged with so far have left feeling like it was a worthwhile experience. And also, you can see where one of the things that I've noted is that as healthcare professionals and providers, we have a tendency to become extremely narrow focused, that you don't see or you don't actually consider that your role in that particular instance, whether it's in an emergency care situation, has implications and impacts in the broader world. For example, you're only seeing the patient, you don't see the extended family relations and how you particularly may have treated or are engaged with that patient may have repercussions right across. For example, if you haven't followed through with a very specific action at the emergency care department and overlook something because of your own bias, and that person leaves the emergency department without care and then dies, the ramifications of that to the family, if it's an elder knowledge holder, the knowledge that's been lost. If it's a mother, the children now do not have a mother, and all of the losses and the cost of that, and making sure that the emergency service people understand that you're not just dealing with one person, you're dealing with an individual that has multiple connections and is of value to their family, to their community, to their nation, and are worth something. So I'll close it there.
Thank you so much, Leah. One of your very first statements really sat with me, which is one of the core findings of your research, which is that First Nations expect discrimination and therefore avoid seeking care. And I think those of us deep in this space recognize that. But it's a really important grounding fact to emphasize across this work. Really also appreciate your emphasis on the process associated with doing research in this space in order to ensure that it's done well. I think, and that assessment of readiness at participating organizations. If you go about and invest in the process to measure this, you need to be ready to do something about it. And so we want to make sure that that readiness exists and that there is that buy-in and commitment to actioning what the outcomes of this work are. And having had the opportunity to hear about the simulations previously, I just think that's so cool and such a great way to be supporting really experiential learning. So I can't wait to hear more about that. And I expect it's going to be a model that there'll be lots of interest in spreading across the country. So thank you. With that, we'll go through the next couple of slides and I'll invite you, Tanya, to join us for your presentation.
Great, thank you. Happy to be here. So hello everyone, Tansei. Thank you, Nicole, for the introduction earlier, and to Elder Monique Manak for the opening prayer and for starting us off in a good way. And thank you, Healthcare Excellence Canada, for having me here, and also for everyone here today as I begin to present a Métis approach to addressing anti-Indigenous racism in healthcare. So again, thank you. Can I go to the next slide, please? Okay, so in the beginning, Nicole already introduced me. However, I will speak to a little of who I am. I am a proud Cree Métis woman, mother and cookum from northern Saskatchewan, Manitoba. And it is through these parts of my identity that ground me in the work that we do at MNS, and which allows me to continuously pursue a deeper understanding of what it means to be Métis, what it means to be Indigenous, and what it entails for Indigenous and Métis people seeking to build a healthy and prosperous life in this great nation we call Canada. For the Métis across the homeland, they have unique health needs. Oh, sorry, if we could just, oh yeah, they have unique health needs distinct from Indigenous and non-Indigenous groups. And it is important to first understand who the Métis are to fully understand the approach taken by MNS to meet those unique healthcare needs. Can we go to the next slide, please? So who are the Métis? The term Métis translates to mixed and describes the direct children of First Nations people and Euro-Canadian settlers. However, Métis are not only defined by blending of two worlds, but by our collective history and experiences. The Métis emerged as a distinct Indigenous people in the historic Northwest during the 18th and 19th centuries, and are defined as individuals who self-identify as Métis, have historic Métis Nation ancestry, and are distinct from other First Nations people, and are accepted by the Métis Nation. Métis are strong people who celebrate distinct kinship, traditions, languages, culture, politics, governance, and history. We are resilient, bold, and hardworking people whose passion for independence as free men has contributed to the economy that has allowed Canada to exist throughout history and continues to motivate Métis to remain distinct and independent. Can I go to the next slide, please? It is important to understand who the Métis are and our shared past, so to better understand where we stand now and how we fit into society today. This history is not common knowledge, though we are working to change that. And it directly impacts the interactions healthcare providers have with Métis patients and their families, which is why it is so vital to know the history. Learning about Métis history, including the impact of colonization and forced assimilation policies like residential schools and day schools, provides a deeper understanding of the complexities that are still impacting Métis health and well-being today. It is only by acknowledging the histories of Métis people that we can create policy, research projects, programs, and services that provide solution to the health disparities experienced by Saskatchewan's Métis peoples, and this includes going back to community to work alongside them to figure out what good health means to them and how culture and health inform one another. Can you go to the next slide, please? At Métis Nation Saskatchewan, our vision of health states that MNS is a healthy, self-sustaining, sovereign nation that is rooted in Métis culture, language, values, and community. Our government will act in solidarity and to protect and advance our traditional homeland and the rights of our citizens under Section 35 of the Canadian Constitution. The work of the Ministry of Health is to uphold these values and work with committed organizations and agencies that want to create collaborative relationships to address the health needs of Métis citizens. Next slide, please. So you could see here some photos on the slide of engagements MNS Health has facilitated with citizens, and a word map from one of those engagements highlighting themes and values that are important to healthcare. These include language, traditions, medical travel, access to care, and communication. We at MNS Health really believe strongly in the notion of nothing without us, or nothing about us without us, and creating space for citizens to share experiences, stories, and teachings is integral to the work within our department. Can we go to the next slide, please? Addressing the Indigenous specific barriers and racism experienced by our citizens is a top priority for MNS Health. Through the work of our MNS Patient Support Worker Program, Patient Advocate Program, Métis specific healthcare resources, and our new ongoing work of creating a cultural safety framework. It's through these projects we are directly working to change the care experiences of Métis people here in Saskatchewan. Can we go to the next slide, please? So I'll start off with our Patient Support Worker Program. This program offers Saskatchewan Métis citizens that are registered with MNS or in progress to citizenship patient support during in-hospital stay and provides support such as language interpretation, medical travel assistance, and connecting them with other MNS essential services or wraparound community services. We currently have 2 full-time patient support workers, one in the Saskatchewan region and the other servicing the Prince Albert area, which both help patients being transferred from their home communities or live within the urban areas. Referrals come through Saskatchewan Health Authority via the First Nations and Métis Health Service Unit, as well as through the MNS MAPAMI Center and Medical Travel Program. Our patient support workers serve as a safe, trusted person for citizens to connect with and ensure that their culture, language, identities, and needs are respected and uplifted during their hospital stays. Can we go to the next slide, please? As for our patient advocate program, I like to describe this as the next level of support from our patient support workers. The role of the patient advocate is to ensure that when there are concerns from citizens about the quality of care that they have received, including when they are on the receiving end of anti-Indigenous racism, that the appropriate person within the healthcare setting is notified and a solution can be found. The patient advocate also works to ensure that the design and delivery of care and services are patient, client, and family-centered and are designed and delivering using a culturally safe approach. We currently have 1 patient advocate that supports the entire province of Saskatchewan, and it is one of our future goals to scale up the work of this program to more effectively meet the needs of citizens. I just want to also kind of add in here as well too, our patient advocate actually just supported a recent citizen who did experience some racism in the healthcare setting. There was an actual news report on that, and I do have to stand behind our patient advocate in the role that they played in supporting that citizen. So I can share that link in the chat after we're done, but I definitely wanted to highlight that because it's exactly showing exactly where our patient advocate is supporting citizens when they need to address their concerns. So can we go to the next slide, please? So in addition to those programs, MNS Health has also created a number of culturally informed health resources to support citizens, including our Cancer Care Guidebook and Companion Journal. This guidebook was created with direct support from citizens who shared their own personal experiences navigating a cancer diagnosis, allowing us to design a resource with advice, lessons, and information reflective of the distinct physical, emotional, and spiritual needs of our citizens. We have been so proud of how well this guidebook has been received by community and by our partners, and are in the works to provide 5 more guidebooks on a variety of health topics, including cardiovascular care, diabetes, and kidney care, to name a couple. Importantly, a lot of attention was given to ensure the writing of these resources was in plain language, and they have also been translated into Michif, a distinct language of the Métis. Can we go to the next slide, please? As I mentioned earlier, MNS Health is in the middle of creating a cultural safety framework. Initial consultation for this work started in February 2024, where we invited elders to spend a day with M&S staff exploring what cultural safety in healthcare means to them. On this slide, you will see an image of a live graphic recording that was taken during the elders gathering, capturing the themes and topics of discussion. As you can see, there is a big emphasis on staying connected to cultural traditions and practices, relying on a holistic definition of health, creating more connections between elders and Métis youth, and of course, more Métis representation in the healthcare system. Can we go to the next slide, please? The next stages of this work are to reconvene a group of elders, M&S staff, and stakeholders to turn these themes and values into a formal document, and eventually work with our partners in healthcare to create an implementation plan for this framework. The goal of this work is to utilize this framework to help educate frontline healthcare workers, policy writers, and others who work in the healthcare system on what it is needed to provide culturally safe care to Métis patients and their families here in Saskatchewan. And also too, not just in Saskatchewan, but we hope that this framework will be also an example to use across the nation as well too. But here we're starting in Saskatchewan. Can I go to the next slide, please? So with that, I conclude the end of my presentation. I would like to take this time to thank you all for allowing me to share and for taking the time to listen, as well as giving me the opportunity to highlight the hard work being done by the M&S Health team, and also through the work that we're doing with our partners to address anti-Indigenous racism in healthcare. Again, thank you, and merci.
Thank you so much, Tanya, for joining us and for the opportunity for folks to learn about those distinct experiences of Métis in Saskatchewan. I think when you talk about the work of the advocates that you have, it's such an important role, both in terms of providing a safe place for patients and families to go to when they know that something is not okay, that they've experienced care that was not safe. And also supporting advocates so that when they do hear these stories, there's a way that they can translate that into the system change that's required. So they have a place that they can bring those messages forward to support the change that is so deeply needed. My colleague Kaylee just added in the chat a video that Métis Nation Saskatchewan produced that tells those stories of what cultural safety looks like for Métis in Saskatchewan. And there's not a lot of resources out there that are specific to Métis experiences. So really happy that we were able to work with M&S in the production of that video and encourage folks to check it out. And with that, you're up next, Hilary. If you could please join us and we can go to her slides.
Atilia, hi, welcome everyone. Thank you so much to those who have shared their knowledge thus far, and of course to Nicole for the introduction. As Nicole mentioned, my name is Hilary Fry, and I'm a proud Labrador Inuk with mixed ancestry. My dad's side of the family are from Nunatsiavut, and my mom's side of the family are settlers from the island portion of the province. I was born and raised and am calling in from Goose Bay, Labrador, which is located just outside of the land claims area. I am the former Indigenous Health Relations Manager with the Nunatsiavut government, and my role was to advocate for culturally responsive services and culturally safe care to Labrador Inuit. And as a registered nurse and beneficiary of the Labrador Inuit Land Claims Agreement, I'm very passionate about achieving health equity for our people, one of the ways being through combating anti-Indigenous racism. I would also like to acknowledge that my passion does not translate to knowing it all, and that the commitment to providing culturally safe care and being anti-racist is a journey of lifelong learning. I appreciate this time today and would like to take the opportunity to share the great work that has been happening collaboratively between Newfoundland and Labrador Health Services, or NLHS, which is the provincial health authority in our province, and the Nunatsiavut government as our Indigenous government. NLHS had recognized the need to improve the collaborative relationship between our organizations as we both provide essential health services to Labrador Inuit and ultimately improve culturally safe care. NLHS then invited the Nunatsiavut government to partner on this very important work. Next slide, please. One large part of this work included the development of an education session to be delivered to healthcare providers working with NLHS. The education was developed by the Department of Health and Social Development within the Nunatsiavut government. This presentation is delivered in person to healthcare staff by myself and one of my colleagues who is a traditional knowledge holder from community and in partnership with NLHS. This presentation is broken down into 4 parts. Part 1 provides an overview of Nunatsiavut, which translated to Inuktitut means our beautiful land. Here we discuss our communities and what services are available. For example, an important consideration for healthcare providers is that our communities are fly-in, fly-out only, and there are no retail pharmacies. So, for example, with discharge planning and such, it would be important to be aware of this to ensure that folks are leaving hospital with adequate supply of medications and things like that. Part 2 describes our self-government, the Nunatsiavut government, which is important because other governments and providers have a legal obligation to consult with the Nunatsiavut government as our own self-government when it comes to decision-making that impacts the NG or its people. And, you know, the relationship that the Nunatsiavut government has with the province should be a government-to-government relationship, hence why we emphasize that. Part 3 discusses the Department of Health and Social Development within the Nunatsiavut government. Providers must understand what community-based services we offer to our people so that we can work together most efficiently and improve care delivery. For example, in community, the Nunatsiavut government provides home care and public health nursing, but acute care or emergency care is provided by NLHS. So as you can see, it would be really important to understand who's responsible for what to ensure the best outcome for the patient. Next slide, please. And most importantly, part 4 involves the knowledge sharing of the Labrador Inuit, the historical impacts of colonialism, and the many health implications as a result. More specifically, we discuss Inuit culture, colonialism, including Spanish flu, forced relocation, and residential schools, and how that has resulted in historical and multi-generational trauma. We also discuss social determinants of Inuit health, cultural safety, and then how that translates to healthcare delivery, including some do's and don'ts and some basic Inuktitut and healthcare, where myself and my colleague actually do a live exchange. And I'm going to talk a little bit more about that as we go on. Next slide, please. I just wanted to provide folks on the line with an example of the invitation that we send out to participants. So far we have presented to 3 groups of managers and physicians within the 3 main sites of the Labrador-Grenfell region within NLHS. We've also presented to a group of medical students and residents, a new group of registered nurse starting work in the Goose Bay region, and to senior leadership within NLHS. It has been very well received, with many additional requests to deliver this education in the future. The overall goal is for all staff working in the region to receive this mandatory training, and again, in person. Next slide, please. I just wanted to share a couple of photos of myself and my colleague, Sharon Edmonds. These photos were taken when we presented our work in St. Anthony. As you can see the photo on the left there with Sharon, this is how we open the presentation with the traditional ceremony, which is the lighting of a huldik. And this is a traditional lamp that was used for years by Inuit using seal or whale oil, used for heating homes, light, cooking. And we are both wearing our traditional clothing known as a akolek. We also stop mid-presentation for a health break where we share traditional food. Typically, we have smoked char with cheese and crackers and berry tarts, and of course, take that time to have a more informal, meaningful conversation with participants. Next slide, please. During the presentation, I also described cultural safety and how it must be viewed on a continuum, beginning with cultural awareness, proceeding through cultural sensitivity and competence, and then leading to cultural safety. Cultural safety is defined, as we know, by the care recipient. In simple terms, cultural safety is achieved when the care recipient feels safe accessing and receiving care. They are able to comfortably include their culture, communities, and identities into their care plan. And of course, we know that culturally safe environments are free of discrimination and racism. Providers must practice cultural competency while simultaneously reflecting on one's own biases, privilege, and what power imbalances exist. The historical context of colonization and the mistrust of different systems, such as the healthcare system or the government, must always be at the forefront. It is not as simple as just attending a cultural awareness training for each individual provider. The immersion into one's culture and physical environment is also an effective tool in working towards the achievement of culturally safe care. It's also important to note that the change must start from the top. Frontline providers can be the most culturally safe anti-racist practitioners, but when they work within the constraints of a colonial system, then there will be continued negative experience for Inuit and Indigenous people. Institutions must decolonize their structures, policies, and thus practices. Organizations must prioritize the specific views, values, and needs of Indigenous populations that they serve. Policies that indirectly impact health and well-being must also be taken into consideration, not just the healthcare specific, but things like food insecurity and subsidies, housing availability and cost. And when we think about policies, we need to make policies fit the people, not people fitting the policy. Next slide, please. The presentation itself includes a lot of information, which could be spread into days of learning, but given the capacity we have to provide the information in a realistic amount of time, I like to summarize the most important takeaway messages when it comes to healthcare delivery into do's and don'ts format, do's and don'ts format. And I would like to take the opportunity to share some of those messages today. Next slide, please. I think too, although this has been identified as being important for Labrador Inuit, I think a lot of the do's and don'ts that are shared here can be just applied to basic healthcare interactions as well. So the first being educate yourself on the Indigenous groups you are caring for. It is your responsibility. So I think about myself as a young nurse coming out into practice and getting my report and for the day on my patient assignment and recognizing, okay, I've got to do a catheter change at 10 a.m. and maybe I haven't done a catheter change in a while. But as a new nurse who hasn't done that in a while, I'm going to go and I'm going to look up that skill and I'm going to make sure that I'm going to do it without, causing harm to the patient. And I feel that being educated on the Indigenous groups you're providing care to should be thought of in the same manner to ensure that you aren't going to be causing unintentional harm. Examine your privilege and check your biases. Take into consideration the historical forces of colonialism and how that contributes to a mistrust of the healthcare system. So I often think about a interaction I had with an individual who works within the system, and they were complaining, and I understand the frustration, but they were complaining about how they were having all these no-shows from folks who were agreeing to the referral, but then not showing up for their appointment. And a lot of the folks that she was referring to were Indigenous, and so I took the opportunity to share and say, historically, if a provider, and not even historically, but really today, for a lot of Indigenous folks, if a provider who's in a position of power tells you that you would benefit from a service, that they don't necessarily feel that they're in the position to say no or decline the referral. So maybe your no-shows are the polite way of saying, I'm not interested, but I didn't feel comfortable sharing that in the interaction when I accepted the referral. Acknowledge power imbalances and enable a reciprocating partnership versus taking an authoritative approach. Practice client-centered care, which is holistic in nature, including physical, mental, emotional, and spiritual aspects. Allow for cultural aspects in care provision, such as traditional medicines, Indigenous specific ways of healing. Maybe it's consumption of berries or seal oils or other products, for example. Utilize a trauma-informed approach to care. So instead of asking, what is wrong with you, try thinking, what has happened to you? and take into consideration harm reduction principles. Next slide, please. Enable self-determination and respect informed decision-making, even if it goes against your own personal belief system. Establish realistic goals for care. Engage family members in care planning if desired. If you're, as a provider, hosting a family meeting around someone's care, perhaps have a sharing circle and ensure that if you are having a family meeting in a sharing circle, that you will be going with the sun clockwise. Consider individual determinants of health, again, such as housing or food insecurity. Assess for potential language barriers and engage interpreters as required. And I also like to note that just because someone is bilingual, for example, if Inuktitut or another Indigenous language is their first language, they may be most comfortable having important conversations around their health in their primary language. So even if one can understand English, they may still feel most safe if they are able to communicate in their primary language. Provide a safe space to knowledge share. As providers, it's important to practice self-care to avoid compassion fatigue. And I know that, providers on the line might be chuckling because as a provider in today's system, it is really hard to practice self-care. I know that, folks are overstretched, but it is still really important to ensure that you're taking care of yourself if you're taking care of others. And then finally, being accountable and practicing self-reflection. We're going to make mistakes. That's just the nature of it. But the important thing is that we recognize when we do and we strive to do better. Next slide, please. So now we have the don'ts, and I like to start with the do's, but the don'ts, making assumptions, belittle or talking down to. And I know that that's one of the things that were often shared when speaking with our elders and things, that when they're accessing services, not just in the healthcare system, but systems in general, as Inuit or Indigenous people, they often feel like non-Indigenous providers speak to them like they don't understand, like they're children, and that's really hurtful. Cater care to fit the westernized biomedical model, not using a deficit-based approach. So use a strength-based approach instead. So, say you have an individual who is on sliding scale insulin. And so, provider might look at that and say, well, they're on sliding scale insulin, so they must have poor eating habits. Well, instead, change your way of thinking and say, this individual manages their sugars with sliding scale insulin. That's really challenging. So they're really good at medication management. Underestimate the importance of nonverbal communication. So things like eye contact, touch, position of body. For Inuit specifically, eyebrow raising or nose scrunching. So eyebrow raising could mean yes, and nose scrunching could mean no. Assert dominance. Do not tell care recipients what you are doing. Instead, ask what works for them. Plan care according to the provider's idea of wellness. So again, Indigenous wellness looks very different than the westernized physical wellness in absence of disease. Exclude families or communities in care planning. Again, very important part of wellness. Use complex words and medical terminology. So again, really important to meet the patient where they are at. And finally, do not discredit traditional ways of healing. Next slide, please. If my colleague was here with me today, we would share with you the Inuktitut in healthcare that we often see. And so she and I actually do a live interpretation. So I would say the English version, and then she would share the Inuktitut version, which was a really nice way to close out the presentation that we do together. But unfortunately, she isn't here, so not able to do that. But just wanted to share that with folks on the line to provide, additional context to how our presentation plays out. Next slide, please. And same thing, so just in a second slide of some Inuktitut that you may encounter when caring for Inuit in the healthcare system. And then last slide, And I wanted to take a quick opportunity to share that since this presentation was developed, that there was actually a part 2 of our work with NLHS, and that included us flying leadership within the health authority to communities in Nunatsiavut, where we met with community members and local providers. And we actually did a patient tracer so that leadership who have never been to community were able to see real firsthand of what it looks like to access services through a nurse-led clinic and then have to be flown out, arrange a medevac and flown out to our community of Goose Bay where tertiary care is provided. So that went off very well. There was a lot of really great learning, a lot of conversations had, and a lot of relationships built as a result of that event. So I just wanted to take the time to share part 2 of this work. So really great work happening. And thank you again so much for this opportunity. It's been lovely sharing with you all today. Thank you so much.
Thanks so much. And your final comments there were a perfect segue into my reflections from what you shared, and what Leah and Tanya also, that just the power of experiential and relationship-based learning. The fact that you emphasize that this training, the hope is that this training becomes mandatory and that it has to be in person, and that you break for food, and that opportunity for relationship building that happens around food. And so, there were some questions in the chat about how can I know more about Métis specific experiences of care and needs in care, and there are some great resources shared there. I think what I've heard today and what I want to emphasize is that you can take a course or you can read a resource, but ultimately you learn the most through experience and relationship. So thank you for your comments today, Hilary. We're running short on time, but I do want to, if we can take down the slides. And unfortunately, Leah was multitasking her time today and had to be pulled back into the other meeting that she was participating in. But I think we'll just do a couple of questions, and my team and myself have been monitoring the questions in the chat. And many of them are such great questions with such complex answers. So I'm going to pick 2 for one for each of you to speak to the best of your ability. So one of the questions was around how to identify First Nations, Inuit, and Métis patients. Like, how do you know that they're coming into your healthcare center so that you can ensure that they have appropriate or have access to appropriate services? And I'm going to give that to you, Tanya. Not to give the answer for the entire country, but perhaps an example of some ways that that's being done well.
Okay, when I think of this question, I'm just going to take it from a personal experience. Sorry, I totally forgot that. That was up there. So when I answer this question, I'm just going to take it from like my own personal experience. I find that there's a way to ask, and then there's a wrong way to ask, right? The way to ask is just, approaching someone and saying, I would like to, provide you the healthcare that or the support that you need. Do you identify as First Nation, Métis, or Inuit? And allowing that person to fully provide that answer. Yes, I identify as Métis. Yes, I identify as First Nation. It's simply asking. Rather than coming in and saying with a, your little booklet and saying, do you identify as First Nation, Métis, Inuit? And then checking off the box. To me, I find there's 2 separate ways. And it's just allowing yourself to meet that person and really wanting to get to know who they are. There's no wrong way in asking that, but there is in a way when you're trying to just check off the box. That's the best way I can answer that question.
Thank you.
Yes, yes.
I appreciate it. And I think many of us have experienced that done not so well. I know I have my own stories of where it's someone with the clipboard and the categories are like don't even make sense to me as an Indigenous person. That's my personal favorite. So appreciate
Exactly.
that. It's about relationship and taking that opportunity to ask a question and get to know the person that's presenting in front of you. And as Leah said, is someone who's seeking help and healing. Thank you. Okay, Hilary, this is a tricky one also. um, I think, there's lots of efforts across the country to better assess the degree to which racism is happening and being experienced in the healthcare system. There was a question in the chat about, do we know if it's worse in some parts of the country or other parts of the country? My response to that person's direct question would be, we don't know that because there isn't consistent measurement happening across the country. So my question to you, though, would be, how do you know if this work is making a difference? What are some ways that you can measure improved cultural safety?
That is a really good question, but also a really tough question. And I feel like, to be honest with you, when I say we, I think, the country in itself is so early in our journey in addressing anti-Indigenous racism and looking to improve culturally safe care. Ultimately, I think that, if the Indigenous patients are reporting a more positive experience themselves, and that is the true measure of cultural safety. But I think it's going to take a long time for us to be able to get there. I think in the meantime, though, that if we have non-Indigenous providers and systems approaching us with curiosity and looking to improve service delivery by co-developing events or education like this, then I think that shows us that, we are going to see an improvement in care. But I think it's going to take a really long time to get there.
Thank you. I have days where I feel like it all feels so big and complex, and then I have days where I feel incredibly uplifted with hope and hearing about the amazing work that is happening across this country. Um, I'm gonna shift us back to the slides, if we can put those up. Oh, and I did just want to note, in response to several of the other questions asking about resources, we will be sharing the slides with some resources to all participants in the coming days. So you can look for that. So as we draw to a close, another reminder about the ongoing activities associated with Canadian Patient Safety Week. So we have a session on October 30th to talk about safer care in the community, and another one on November 26th with the topic of courageous leadership, which I love that title. And you can visit the CPSW homepage for more information or scan this QR code on your screen to register and to join our email list. Next slide, please. So we always want to know how we did and how we can do better. So we're going to launch a couple of questions and encourage you to respond to those so we have a sense of who's here and a little bit of feedback on today's presentation. I'm just going to pause for a few moments while that gets completed, and then we'll invite Monique to close our session. Okay, I want to make sure, Monique, you have enough time to share. So I'll invite you to come on back.
Hello. You're muted.
Just said hello, my friend. So
Oh, hello.
over to you.
Thanks. I'm so inspired by what I've heard today. There are so many factors that are encompass and are a part of the treatment that Indigenous people receive when they go through the medical system. I'm reminded of I had started working with a project out east where they were saying that in the Atlantic provinces, they were saying that a huge percentage of Indigenous children weren't being properly diagnosed. And they realized eventually that it came back to how those questions, yes or no, what level is your pain? These short, abrupt questions. And the kids, there was no context, and the kids didn't know, how to respond. And so, or what was being asked of them. So, what they found, and I think they were actually developing software for this, what they found was that if they created an opportunity for these kids to speak their narrative, tell their story, if they stopped and they listened to what these children were saying, then they were able to they noticed a big difference in diagnosis. A kid doesn't know the difference. Like, I know myself, sometimes they say, how much is your pain from 1 to 10? It's like, compared to what? So if they listened and if they, created a space where these kids felt safe to speak their story, then they found that there was a big difference. And I think that's something that I'll try to look up who it was and send you that information. Yeah, exactly. When you're asking with genuine interest, not just hurry up, like that, the kids would go silent. They wouldn't respond because they thought they didn't know what was required or wanted from them. So along with all these other steps and education that needs to happen, to look at how Indigenous methodologies would really benefit, like the medical system would really benefit from these Indigenous methodologies. If we continue with all that hard work, then we may actually find that we do create improvements. So I'd like to close this space. And in doing so, please take everything you've heard today. Once again, I have learned so much. I love the presentations. Everybody was so articulate and made me think of things that hadn't even occurred to me before. And so please take all of that and share it with your colleagues or your families. Or, I always say that sometimes when I learn something in one area, all of a sudden I find it pops up somewhere else. And so, if we take what we learn here, then maybe, it can apply in other areas of our life. So I'll close this space and with a few words to the Creator. Kachimigwich Jemnido. Thank you, Creator. Thank you for the water, for the plants, for the trees, for the ones who fly, for the ones who swim, for the ones who crawl, for the furred, for the feathered, for the four-legged, and for the two-legged. And thank you for bringing everyone together here today with open hearts, open minds. Help us to see truth. Help us to hear beauty. Help us to speak with kindness and with compassion. And help us to work together for the benefit of all of our communities. Kachimigwich, 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 Kachimigwich. Thank you very much. I hope you have a terrific week and weekend. Thanks.
If we can put the last slide up, I will say Kuyanamik, Marcy, Miigwech, Merci, and thank you to all of you, as I said, who could be many places and decided to share in this space with us today. And a special thank you to Monique, to Leah, to Tanya, and to Hilary for guiding us in this conversation. I hope we've left you all with lots to consider. And as I said, we will share the slides, and a recording will be available of this. And our communication will include some resources. Wishing you all a wonderful rest of your day.